Good morning, everybody. It is a pleasure to be here on a most beautiful day. I guess you couldn't ask for a better day to come to Vancouver. It's absolutely beautiful today. So I'm looking forward to spending the day afterwards. What I'm going to attempt to do in the next 45 minutes or so is talk a little bit about what the state of the art or what options we have in choosing an incontinence procedure today. Now, I'm going to try and keep things as evidence-based as I can. When talking about surgery, it's hard not to let your own personal biases come in a little bit, but hopefully, at least when there is my personal bias, it'll come across as that and not come across to you as something that's written in stone. I think that's important when we look at the spectrum of things that are available and the way things have changed. And certainly, I have changed the way I think about stress incontinence surgery in the last 4 or 5 years, really based on a lot of things which I think will become clear as we go along. Now, we're not going to talk a whole lot about pathophysiology, but I think it's just important to think of two things when we talk about correcting this problem. We're correcting this problem surgically. We're really going to be talking mostly about surgery this morning, and that's not to discount other ways to treat the problem. But we know that we have this sort of, in many women, this support defect. It is called hypermobility. I think a better term is a support defect, where the way that the backboard of the urethra normally works is that when there's a rise in abdominal pressure, the urethra should come against this nice backboard that sort of goes from the arcus to the arcus, and that will allow the urethra to be compressed and not to leak. So that's why most women don't lose urine with rises in intra-abdominal pressure, whether that urethra moves a little bit or doesn't. And when that support is not there and becomes deficient, that's one of the ways in which stress incontinence can occur. So we're thinking already, okay, well, when we fix this, how are we going to fix that support defect? And certainly the integral theory, which was proposed a number of years ago, it talks about that sort of vaginal hammock in relation to the pubourethral ligaments and the pubococcygeus muscle and how they work as a unit. And I like the more simplistic way of thinking about it that I spoke about first. The integral theory can be conceptually a little bit difficult to understand. And then we just sort of have the intrinsic urethra. And we know that intrinsically the urethra can fail. It sort of has this nice, thank you. It sort of has this layer of this nice spongy vascular layer, the submucosa, surrounded by some muscular layers, and it will keep the urethra collapsed so that when that breaks down, you can have a problem independent of any support defect. Now, that's what we call intrinsic sphincter deficiency. I think that we have to be very careful when we define ISD. ISD has been recently defined by a number of urodynamic parameters that really, in my mind, are quite arbitrary. 60, 90, they are arbitrary in the face of a support defect. So I've sort of changed my thinking a little bit, and I really think when I think about different procedures for incontinence and ways to treat it, I tend to think of how much mobility is there and don't think so much about leak point pressures anymore. Clearly a urethra that doesn't move at all by any way in which I can determine is one where there's ISD regardless of a leak point pressure, and when there's a support defect, there's a support defect regardless of the leak point pressure. So I've gotten away from using leak point pressure except in very select circumstances to help me decide what to do, although I haven't gotten away from the concept of ISD. So again, just to summarize, we need stable supporting structures, we need an intrinsically working urethra and bladder neck, and then there's also going to be the contribution of the compensatory mechanisms, the levator muscles, etc. There are certainly women who have a tendency towards stress incontinence, but by using certain compensatory maneuvers, contraction of the levators, etc., can overcome stress incontinence. So here's sort of our array of treatments, from behavioral modification to exercises, medications which are not particularly good at this time, but in the future maybe, devices, bulking agents, which we could almost throw into the surgery category as well, and I'll talk briefly about that in an algorithm at the end, and an artificial sphincter, which at least for me And I think in North America it's not the most popular treatment for stress incontinence in women. It seems to work best as a primary treatment. When you start to use it as a salvage procedure, it is very difficult to dissect flames and get an artificial sphincter where you want. At least it is for me. So when we think in broad terms, we can divide operations into suspensions, which really sort of recreate or fix the backboard that's broken, or slings, which really replace the backboard. Now, when I grew up, suspensions were the main operation that was done. In this generation, and for the residents, slings are certainly the more common procedures that are done for stress incontinence in North America and throughout the world. What we do know is that retropubic suspensions, your Birch procedure, MMK to some degree, and sling procedures seem to hold up the best. And the old needle suspensions that we did and the anterior repairs that were popular amongst gynecologists really don't have the same staying power, at least at 4 years, which isn't all that long of a time. But when these AUA guidelines came out in 1997, what it did, it was sort of almost the final death of the anterior repair and the transvaginal needle suspension. And most people now, in most cases, and you can certainly come up with exceptions to the rule that are very appropriate, rely on either retropubic procedures or sling procedures as sort of the procedure of choice. So what do you do as you sit back and you say, what operation am I going to do for my patient? I think you have to look at the condition. You have to look at what outcomes are available, and I think that's important because certainly in the United States anyway, there has been a major push to use different techniques, different materials that really have no evidence that they work very well. And again, not saying it's inappropriate to use those techniques, but I think that you have to realize when you're using them, and the patients should know that you're using them and why. And then, of course, there's going to be some surgeon preference involved. We don't want to take ourselves out of the equation and say everybody should do the same thing, and that's the only way it should be done. So I'm going to talk mostly about slings, but here's just a quick slide of the retropubic suspension. I've always liked the Birch better. It makes more sense to me than putting sutures really in the urethra. However, when you look at the MMK data and speak to people that have done a lot of MMKs, they'll tell you that the procedure has worked pretty well for them over the years. So again, this is a personal bias of mine. I still do Birch procedures, and actually did one a couple of weeks ago in conjunction with an abdominal prolapse repair in a patient. It was a young woman who we did a transabdominal uterine suspension who also had stress incontinence. And a Birch procedure, in that case, I think was a completely appropriate procedure. So it still is a good procedure. It has been attempted to be done laparoscopically, and there are many talented laparoscopists who do very nice laparoscopic Birches. There are a few that are able to really recreate the procedure as it was described open. But what we don't have is we don't have a lot of good comparative studies and not really good long-term results on the laparoscopic Birch. And what really has happened is, with the advent of some of the less invasive mid-urethral sling procedures, I think laparoscopic Birch has sort of fallen out of favor, and a lot of the people that were doing them, and it was mostly a urogynecologic procedure, stopped doing them because they started to do these other procedures which are easier for them and easier for the patient. So again, it's not to discount that, although there are many, many, many variations of a laparoscopic Birch, and I guess the true laparoscopic Birch is the one that mimics the open Birch as much as possible, not these sort of mesh repair Birch. So that's really a different operation and needs to be looked at in a different way. Now, when we talk about slings, we have a lot of different options: materials, position, length, and operative approach. And here's sort of a list of all available types of slings, or most available types of slings. The classic pubovaginal sling, the mid-urethral synthetic sling, transvaginal bone anchor sling, and I guess in here what I need to put in there as another bullet would be the transobturator sling, and we will talk some about that. So how does surgery affect the procedure that you do? Well, for me, I would say urethral mobility, and you'll come to see that as we go through the talk, is probably the most important factor in myself choosing a procedure in a sort of standard case. The next thing that becomes important for me are complex cases when there's been failed prior surgery, when there's been or where there's been prior problems with synthetics or other materials, or if I'm doing some other type of reconstruction. Then I'm going to move out of my standard algorithm towards something a little bit different. Yesterday, with the residents, we showed a case of a sling with a urethral diverticulum, and that's a case that I always choose to use autologous fascia. I think in that setting, it's the best thing to do. Again, a little bit of bias. Urodynamic parameters a little less important. Occult stress incontinence with prolapse repair, meaning when you have a prolapse, patient does not have clinical stress incontinence, you reduce the prolapse, you're able to get them to have stress incontinence. For me, I've always gone and treated that person as if they have clinical stress incontinence. So I'm going to choose one of the procedures to repair along with my prolapse. So here's what has become the classic pubovaginal sling, a sling that is placed suburethral, that extends up at least into the retropubic space. Some surgeons bring it all the way up to the rectus fascia, but most pubovaginal slings today are done with a little bit of a suture bridge, but the sling does go into the retropubic space and can be done with a variety of materials. In the U.S., Ed McGuire and Jerry Blavis have the longest term series, and again, these series, when you look at them, they're good series that show good results, but they are retrospective. They haven't really been looked. They're not as critical as some of the newer procedures when we present that data. But in any event, I think what sort of is shown here is that patients, this operation done with autologous fascia has a very low recurrence rate of stress incontinence once you get to that first year or two. It seems to hold up pretty well after that. Now, 95 that's not a cure rate that I would ever quote a patient. I tend to be more in the 85% range. I think that makes more sense. But when you add in the persistent urge incontinences and the de novo urge incontinences and all that, I think you're going to come to something more between 80 and 85%. And here's Ed McGuire's data that goes out to 5 years, and I think for me that's a little bit more realistic number to quote a patient. And that's about as good as you're going to do for any operation when you really look at good long-term series. Is somewhere around 80 to 85% in the long run as far as a cure rate is concerned. Now, as the sling became...
Sorry, what was the cure rate of the urgency incontinence?
If you look at this, persistent, and I think in Jerry's... here, if you go to de novo, here is 5%, and persistent is 31%. So basically what that means is, in this series, over 30% of patients had some urge incontinence when they were all said and done. When all was said and done.
Pre-op, what was the prevalence of urge incontinence?
Got cured but the actual numbers I don't know. Most series, if you look at them, their cure rates for urge incontinence are about somewhere between 30 and 70%. Now, what I'm going to show you later are some factors which I think are predictive of urge incontinence and urgency going away when you do stress incontinence surgery. There's a few recent series that actually have some data as to predictability of urge going away. We'll talk about that a little bit later.
You have an increasing percentage of persistent urge incontinence as time goes on, which wouldn't make sense because you'd only have, say, 23% in the first year, and it should be equivalent persistence all through time, or is this just that you selected as a patient?
Well, they're Jerry's numbers, but I would guess what they did was that at 5 years, 31% of patients who had urge incontinence to start with had it now. Now, that's not to say that some of these didn't reoccur over that 5-year period, because again, these patients are getting older, so I would guess that's what happened. Unless it's just sort of a number, because you have a lot less patients in this group, so it could also just be sort of a statistical thing as well. I don't know. I didn't have the raw data on that. So anyway, what we've done is we've now tried to make slings less invasive. In 1997, once that article came out and everybody said, okay, the sling's the way to go, then everybody started thinking, I don't really want to harvest this rectus fascia or fascia lata. What can we do to make the same operation easier and get it to the ease of the needle suspension? That would be really a nice thing. So cadaveric fascia was one of the first things that became quite popular. There's all different types. What I will tell you is Some of them in the lab are better than others, but there's been no trials, in clinical trials, to know in a patient is one type of cadaveric fascial material better than another type of material. Are the two equivalent? I was always reluctant to use cadaveric fascia, allograft fascia. Are they equivalent? Linda Brubaker, who's a urogynecologist, did a couple studies. This doesn't really tell you how good the fascia is, but it tells you a little bit about it. She went in on 8 failures and really didn't find much of a sling in any of them. So she was fairly certain that at least for some patients using some materials, autolysis is a problem. Now, I've certainly gone back on patients that have had cadaveric slings that were obstructed and the sling was perfect. Didn't look like it. But I think it's certain patients and certain materials. When she went back in her autologous slings, now these were obstructed patients, so these all worked, she really saw a scar-like vascularized band that seemed to function as a sling, even though it may not have looked like the same perfect fascia that was put in initially. Fred Govier in Seattle published this study in 2000. He was very excited about the use of cadaveric fascia, showing similar cure rates with much less operative time and much less convalescence, and was very excited about cadaveric fascia. But then, 2 years later, they noticed some intermediate term failures, and that prompted him to stop using that particular cadaveric material. So it seemed that at 1 year it was working pretty well, but there was definitely, at least in some series, a breakdown. This sort of summarizes people who are pro and con cadaveric fascia in here, although even in the ones that are pro, each of them still had some aspect of autologous fascia that seemed to be a little bit better than cadaveric fascia. Only one of this one's reasonably one. This is almost 2.5 years, with about a 71% cure rate, 13% improved. But even this, the patient satisfaction was significantly better with autologous. I'm not sure why, it wasn't reported why, but again, so it certainly brings up some things to think about with cadaveric fascia. So my bottom line in thinking about this is it does reduce the operative time and the recovery time, and the short-term outcomes are similar. The longer-term outcomes, probably you see some drop-off. So I think it would be appropriate for select cases, and I can think of one type of case where I would use some sort of an allograft material, and when we get to the algorithm at the end, I'll show you that. There's been one study recently published on the contemporary pubovaginal sling, as shown in the picture, using polypropylene, standard polypropylene like hernia mesh material. This is from Gopal Badlani's group in New York, and they had a pretty good cure rate. This was placed at the bladder neck, just like the sling. It's not a mid-urethral sling. Pretty good success rate, and Gopal's been using synthetics for a long time, and I think polypropylene seems to be clearly different from some of the other materials that we've had problems with over the years. There are a host of other materials, dermal grafts, xenografts, pelvical, dermatrix, etc. There's not a lot of peer-reviewed literature. There's tons of abstracts, but when you see tons of abstracts that don't make it to the peer-reviewed literature, you got to figure something was not quite right about that series. Why shouldn't these series be peer-reviewed published? Unless the authors didn't want to take the time to do it, but in most cases it's because they don't stand up to the peer review. There's a couple of articles on pelvical by Barrington in the UK, Stratasys in children, which is the small intestine submucosa. That's a small study in children. The pelvical study was from the UK, and this is sort of a continuation of that, or it's actually another study, but they compared pelvical to TVT in a mid-urethral sling, and at a year, there was no difference. So that tells you that at least at a year, pelvical, and that's a product that I personally have never used, but it seems to be reasonable in its results, at least at a year, in a pretty good controlled study, randomized controlled study, but it's only at 1 year. This was an article using porcine SIS, published last year in Urology, and this was with transvaginal bone anchoring, and this had exceptionally good cure rates. I've not seen anything that's duplicated this, that has duplicated this, but it is in the literature by a single group of authors. They did pretty well with that material and that approach. So I would say bottom line, peer review literature suggests pelvic hall is pretty good at a year, but it's 2 articles in the same author. There's no results beyond a mean of 1 year and a maximum of 2 years. And there's no peer-reviewed literature on the other products, unless it's come out in the last couple of weeks. I just searched this recently. Transvaginal bone-anchored sling, a popular procedure among some still done by a lot of surgeons. A lot of surgeons that I know and respect use this technique and love it. Unfortunately, other than that article that I just showed you, if you go to the literature, there's not, whether synthetic or whether cadaveric fascia is used, it's not a very good procedure, at least based on what's in the literature. Now, I've encouraged a lot of my colleagues who do this procedure to please write about it, because until there's something better in the literature, this is what's there. Not all that favorable. And the article from UCLA that came out about 3 years ago, 154 patients using cadaveric fascia, was not very impressive. Now, you don't know if it's the bone anchoring technique, you don't know if it's the fascia that was used, but the bottom line, there's not a real home run article on this, except for that one on the porcine SAS, again by a single group. And this is another one, of transvaginal bone anchored sling. This is from Gary Leach's data presented at the ICS. And again, when you look, this was really a questionnaire study. Even when you look at questionnaire, it's not all that impressive, I don't think, at a minimum 6-month follow-up. Not all that impressive, although Gary is a big believer of this operation. He's been doing it for years. I think if you look at that, again, it's a questionnaire study. He obviously does a lot of them and has confidence in it, but I don't find this to be all that impressive as a questionnaire study, but that's another one that's out there. Now, the mid-urethral polypropylene slings really revolutionized things, or at least revolutionized the way a lot of people look at stress incontinence surgery from when they were introduced in Europe in 1996. The U.S. in 1998. I'm not sure when they were. Probably Canada around the same time. I had always been dead set against the idea of synthetics for stress incontinence. You go back in time and you look at the catastrophes that have occurred with synthetic materials over time, and there's a whole list of them. And I just could never understand why one would do it and put their patients at risk. And when TVT came out, I said, this is a ridiculous idea. It's in the wrong spot. You're using synthetic. It's going to be a nightmare, et cetera, et cetera. And I really thought that way for quite some time. I think one of the differences is that polypropylene, especially loosely woven polypropylene, much to my surprise, really behaves a lot, maybe it shouldn't be to my surprise when you think about it, behaves a lot differently than a lot of other synthetic materials. Because it's loosely woven, these large interstices, infections are very, very unusual. You get tissue ingrowth, it's inert, and the kinds of problems that I thought we'd see with TVT and polypropylene, although you do see them on occasion, no question, but you don't see them at anywhere near the frequency that I would have thought. And one of the things about these different types of materials is that as the pore size gets larger, elasticity decreases and the rate of infection decreases. So the newer materials seem to really be better, and there's a huge experience now with probably close to 1 million cases worldwide. There's well over 500,000 TVTs. There's a number of sparks that have been done. In Europe, there's a ton of obturator tapes that have been done. And at least from a complication standpoint, it doesn't seem to be all that much of a problem. Again, the TVT, the way it was originally described and invented, was based on the integral theory, although I think you can make a good case for how it works by never having read about the integral theory. If you look at the results in a large number, now this is TVT specifically, and there's the most data on TVT, and I didn't put up each and every study, but there are a number of large prospective randomized controlled studies, which all the way up to 5 years, and now some abstract data at 7 years, which really shows the cure rate, at least by the reasonably stringent criteria set forth in these studies, to be in the range of 80 to 85%, as good as those cure rates for the pubovaginal sling with autologous fascia and the birch. There's a recent multi-center trial that this was just published comparing TVT to birch. Very, very, very strict criteria, and there was no difference. Cure of 63 versus 51. Now you might say, oh, that's a terrible cure rate, 51%. But this is really very strict criteria that they looked at. The conclusion of this article is both of these operations are excellent and can be used interchangeably as far as results are concerned. And that's by Hilton, Ward and Hilton. That's a big multi-center study from Europe that was just published in American Journal of Obstetrics and Gynecology. You can find articles, reasonable articles, that support the use of TVT in obese and elderly patients, failed prior surgery, low leak point pressure, although some articles would say it doesn't work as well with low leak point pressure, urethral closure pressure, and with concurrent prolapse. This article here did show a decreased success rate with lower maximum urethral closure pressure. We don't do a lot of urethral closure pressures in urology. It's more of a gynecologic tool, but the TVT was first introduced. When it was first introduced, it was primarily done by gynecologists. So that's why the urethral closure pressure is there. I like this study. It's just a small study, but it sort of helps me again with my algorithm. It's a short follow-up, but what this group did is they looked at urethral mobility. They assessed it by cystogram, and they looked at their success rate, short-term success rate, based upon presence of mobility. And you can really see a fall-off when there is less than 30 degrees of urethral mobility, whether you do it on a lateral cystogram, whether you do it on with a Q-tip test. So the fixed or relatively fixed urethra is going to have a less successful result with a mid-urethral polypropylene sling, we think. And that sort of makes sense when you think about how it works. But the other thing, the flip side of this is you can say, boy, 70% success rate in a fixed urethra for a pretty easy operation, that's not too bad either. So it's certainly some food for thought, and when we get to the algorithm, we'll talk a little bit more about that. No differences when they looked at MUCP. They didn't look at leak point pressure in that study. The Spark is the second most common mid-urethral sling used. It seems that at shorter term follow-up, it works about the same. Here's 4 studies that were presented at the ICS. Results were similar from Jacques Corcos, about the same, no difference. This was the only study from Peter Sand's group that showed a little bit of difference between the two. But I think at least in the short term, the materials are similar, the techniques are similar. TVT classic from below, although you can certainly do a TVT from above, similar to a Spark. So they seem to be, at least in the short term, similar procedures using polypropylene. The complications are not all that big of an issue. Well, the minor complications, bladder perforation does not seem to have any effect on outcome, and it means that the patient's going to, as long as it's recognized, it means the patient's going to have a catheter for a couple of days, and that's about it. Most of my pubovaginal slings are going to have a catheter for more than a couple of days. Tell the patient about it in advance, so if it happens, they don't think it's a catastrophe, they don't think something's gone terribly wrong. Vaginal extrusion of the tape, I would have thought that's going to be a nightmare. You got to take the whole thing out, etc. I've had a couple of vaginal extrusions, and they're handled very easily. You can handle them really right in the office by just cutting the tape out and maybe making a little flap with some local anesthesia. I would have thought that would just be a catastrophe, but it really isn't. It doesn't happen very often. Now, a tape erosion of the urethra into the urethral bladder, that's a bad thing, and that's going to be a big problem. It doesn't happen that often. I've seen a lot of people present these cases where they look into the bladder and there's a loop of tape going around and it's all got stone all over it. Not a great thing. But that I don't think is an erosion. I just think that's a missed tape in the bladder. When you scope these patients at the time of the operation, you can, if you're not careful and do it quickly, miss a tape. And when we do TVTs at our institution with my residents, we probably spend as much time scoping the patient as we do doing the actual operation. You really have to be careful. Vascular injuries have been reported. Bowel injuries have been reported, and chronic urinary retention is about the same as the classic sling. And I'll tell you, I have seen and heard of bowel injuries from classic pubovaginal slings in patients that have put in suprapubic tubes, etc. So these are not things that don't happen with other types of operations. You never like to see them, but they're there, and you do have to be careful, and patients do have to be warned of them. There's several other commercial brands. There's homemade brands. UCLA, they have a sort of a homemade brand where they use the same material as the TVT, but just do it without the kit. Same at the Cleveland Clinic, etc. And in the short term, the data seems to be comparable. So if we look at the sort of the whole with the mid-urethral sling, decreased operative time may take around a half an hour, maybe a little less. You do have a choice of anesthesia. It is an outpatient procedure, low morbidity with a very quick recovery rate, and the 5-year outcomes, at least with TVT, are comparable to any of the other procedures we have, as long as you select your patient properly. What about the newer mid-urethral sling? Here's an interesting idea. These pictures I stole from, with his permission, from Paulo Palma in Brazil. And what he started doing in cases where he was concerned about scarring in the retropubic space, there's the urethra and the pubic bone, that's the classic path of the needle, and they started to pass the needle in front of the pubic bone. And indeed, I didn't even realize that was with a spark. I didn't even realize that Olmston had done a study doing that with a TVT going up the other way on top of the pubic bone was, in short term, kind of similar cure rates. I know that Shlomo Raz has done some of these in certain select circumstances, so it keeps you out of the retropubic space. Sort of an interesting idea. There's not a whole lot of data on that. And now what has become very popular are the transobturator slings. And if you hear the folks from France talk, this is the only operation you should do for stress incontinence now. So we'll talk a little bit about what we know about the obturator slings and when it might be appropriate to consider doing them. It avoids the retropubic space. There is theoretically a decrease in complications. In the one type of approach, one bladder perforation was reported. There's a theoretical decrease in voiding dysfunction. I think from the available data, what you see is that more patients void immediately after the operation, the same day. It probably cuts the retention rate, the acute retention rate, from 20 to 25% to about 10 to 13%. The chronic retention is still in the range of about 2% of people need some sort of manipulation of the sling. It can be done either inside out, the TVT obturator, or outside in. That's the Monarch. The Optape is also an outside in procedure. It got hidden there somehow. And basically when you do this, you want to go in this area and stay away from the vessels and the nerve. And actually, with the kits that are available, it's, I think, pretty easy to stay away from that area. The problem is it's just such an unusual approach for us as urologists. We don't know, we're not so familiar with the various muscle attachments, etc., of that area. But I think, in my mind, it can certainly be done safely. And here you can see this is a commercial picture from Monarch is, I guess, AMS. You can see the tape here and the operator canals all the way over here. So you can stay away from it. This is just operative technique of the outside-in technique. This is the way it was first described, where you're going to mark your edge there of the obturator foramen, put your finger in past this sort of somewhat horrifying-looking device through there, grab the tape and bring it up, and then you have the inside-out technique. This is the one that I have the most experience with. I don't have a huge experience, but where this is fashioned in such a way where you make your incision vaginally and then bring it out. I think it makes the chance that you're going to have a bladder or urethral injury just about as close to zero as it can be. So these are all, and the tape sits like that. Now they're all, looks great, but how well does it really work? And that's what we have to critically look at. If you look at the at the outside-in technique, this is the Uratape, or what's sold as the Optape by Mentor, at least in the U.S., by Porges, I guess, in Europe. It has at 17 months mean follow-ups between 13 and 29, pretty good cure rates. One prolonged retention of 4 weeks, 5 with obstructive voiding, and I think they did take those down. Pretty comparable to the other way of doing it, the TVT, at least in the short term. The article on the Inside Out is just a feasibility study. They did not report any results. And there was one recently published article on TVT versus TOT, and at a year, it was about the same. So in the short term, seems to work as well. Does it work as well in the long term? I have no idea. We have no selection criteria, at least in TVT. What we do know, and these articles will come, but we don't. With TVT, we know that obese patients, reoperated patients, you can use it. In the fixed urethra, you can use it with less success. We don't know with the transobturator slings whether or not that's true. So now as we sort of, again, go back to what factors influence choice of procedure, stress incontinence with urethral hypermobility, mid-urethral slings do provide excellent results with low morbidity. If there's no hypermobility, you may need more tension. If you think that you have a fixed urethra, and again, you don't use a bulking agent or it hasn't worked or whatever, and you think you need to put a little more tension on that sling, and even though we say we don't put slings under tension, I think there are cases where we want to do that. I think in that case, I think a bladder neck sling would be preferred. A little bit of tension at the bladder neck, and I'm not a big fan of the concept of putting tension on a synthetic sling. Occult repair with prolapse, I think occult stress incontinence with prolapse, all are applicable. And in complex cases, again, I tend to go back to the standard pubovaginal, rectus fascia pubovaginal sling. Now, for years, that was the operation I did. And it wasn't until about 3 years ago that I started to switch. When do I use a standard pubovaginal sling? In the fixed urethra, better efficacy, although, one thing that strikes you, and one thing where I've really changed my thinking in stress incontinence surgery, I always grew up with the idea that we got to do the best operation for the most successful operation for the patient, period. And I think when you start to see how much less morbidity there is with some of these procedures, it has to factor in the fact that you get good results and 2 or 3 days later a patient is back doing whatever it was that she was doing before, whereas at least my pubovaginal slings took a couple of weeks before they were back to normal. So there is definitely something to be said for that, and I don't think you really sacrifice a whole lot in terms of success. Now, that's not to say that 10, 20 years from now, I may not be eating these words when I say I can't believe all these long-term complications of all this synthetics that we put in. That's certainly a potential risk that we have to think about. Prior problematic synthetic slings, I don't go back and do another one. Significant radiation changes, I'd be a little bit reluctant. Again, simultaneous reconstruction. And then after I tell the patients the pros and cons of all these things, some patients will opt to say, look, I don't want any synthetic, I don't want any animal materials in me. I will choose to do an autologous sling. The one case where I might consider a biological is in the elderly patient with a fixed urethra that I want to do a bladder neck sling on, and I really don't want to take that 82, 83-year-old woman who failed a bulking agent and put her through the fascial harvest. And in those cases, I think that's the one indication for me for a biological sling where I'll still use it. So here's a little algorithm I've come up with. It's a little bit complex and not so straightforward, but I think here's how I approach the patient. Patient has stress incontinence and they desire definitive treatment. Right away, we talk about surgery and bulking agents. I have no problem using bulking agents in all types of stress incontinence. I don't really care if the urethra moves or it doesn't move, and I think if you look at the data that's out there, it really doesn't matter. The problem with bulking agents is they have a different expectation. The patient is much more likely going to be improved than cured, and about 25% of the time it flat out just isn't going to work. But it is simple and easy. It does, at least the agents we have now, it is going to need to be repeated down the line. Having said that, it's simple, it can be done in the office, and it takes a couple of minutes. So I don't exclude anybody from a bulking agent, although I must say that if somebody's 45 years old and they've decided they're thinking very seriously about collagen, and I know that all that animal antigen is going to be injected into them over and over and over again over the years, it's something they may want to think about. But again, I don't exclude patients because they have mobility from a bulking agent, although I also don't encourage it wildly. But I think that it's a choice that the patient has to make based on expectations. Surgery, if the urethra doesn't move, I prefer a bladder neck sling, usually with autologous fascia. You can consider a mid-urethral polypropylene sling, a TVT, a Spark, etc., but the success rates are less. So the patient has to realize right off the bat it's an easier operation, but it's based on what we know, it's not going to be quite as good. I don't know where an obturator tape falls into there because I've seen no data on the fixed urethra. I do have one patient that I've done an obturator tape on who did have a relatively fixed urethra, and the reason that I chose it was because she had had a neobladder, and I knew if I did any other type of sling, I would have to really go back and do an open operation. Don't know if it's going to work for her, and I told her that, but I chose it for that reason. The urethral hypermobility and a high leak point pressure. Okay, I said I don't use leak point pressures. The only reason I would use a leak point pressure is I would not do a retropubic suspension if there was a low leak point pressure, because there is some data to suggest that they don't work as well in that case. But otherwise, the mid-urethral sling, the bladder neck sling, and the TOT would be options. When I think it's reasonable to do a TOT is, again, explaining to the patient exactly what we know about the operation. Obese patients and in patients who have had multiple prior retropubic surgeries. I did a TOT on a patient who had a big bladder neck construction when she was a child, and ureteral reimplant, etc. And I said, boy, if I could stay away from that area, it would be nice. So we tried it in that. I have done TOTs on a couple of patients selectively who had pretty straightforward standard stress incontinence, and when I explained the procedure to them and what was involved and what we knew about it, they made the choice to do that. It was a very informed choice, so I still would use the typical mid-urethral polypropylene sling over that unless the patient chooses based upon that. Now, I said I had some slides here on, I guess I left them off this, but I'll tell you what's now out there on mixed incontinence. There's a couple of studies out there, one particularly good study where they took patients with mixed incontinence who had a normal CMG. So they complained of urgency and urgent incontinence. When they did the CMG, it was normal. Now, that doesn't mean they don't have detrusor overactivity, but they had a negative CMG, so you have to assume that their detrusor overactivity is not a wild kind of detrusor overactivity. And what they found was they randomized those patients to surgery, either birch or sling, or anticholinergics. And when they looked at things down the line at 6 months, none of the anticholinergic patients obviously had an improvement in stress incontinence, where 90% or so of the surgery patients did. But the cure rates for the urge symptoms were much higher with the surgery than they were with the anticholinergics. So that was mixed incontinence, but a negative or normal cystometrogram. So I've actually used that as a prognostic factor and tell patients, I never tell them it's going to go away exclusively, but if they have a negative cystometrogram, I will tell them I think the chances of it going away are better than if they have a lot of high-pressure involuntary contractions. The other study that was done, which was done at the University of Iowa, Carl Kreter and Ingrid Nyberg, a combined urology gynecology study, they looked at type of instability. And what they found was that low pressure involuntary contractions or overactivity. See, I use that word instability again. I told you not to use that. Low pressure involuntary contractions, those patients had more of a resolution of their urge symptoms than the high pressure contractions. So they brought it out based on pressure. So there is some limited data that would suggest that the more prominent the detrusor overactivity is on urodynamics, the less likely it's going to go away, and that would seem to make sense. And there is some data out there to support that. So I actually use that in counseling patients now, at least women with stress incontinence. And And again, if there is significant urge, I usually always will attempt to treat that first, and then when that becomes unsuccessful, then we'll move on to surgery if the patient wants. So that's all I have to say formally. I'll be happy to answer any questions.
I just wanted to ask what you do about dealing with the incontinence when you run across a catastrophe where you've got a major urethral erosion and stones that you talked about, so you get it out to you repair the urethra. Now, what do you do about the incontinence? Do you do it at the time of that repair? How much later do you do it if you do it at a different time, and what you suffer?
I would generally not do it at the same time because you know, it's not to say you can't, but when you have those sort of catastrophes, let's fix the one thing before we potentially create another one. So I will do that, and then I would almost exclusively, you know, if I could get away with a bulking agent, that would be wonderful. Assuming you can't, that's the case where I would prefer an autologous. Assuming the patient needs another sling, an autologous sling, either rectus or fascia lata. That I think is the ideal case for it because they've done poorly with whatever. And even if it was an autologous sling catastrophe, I would probably go back to that again. But I've tended to not do those at the same time.
What's your time separation?
I would say at least 3 months. That's what I found. You know, when you go in before that, it's a little. Now, you know, that would be what I do. I don't want to speculate and start coming up with all these new procedures that might work. That's how I'd handle it.
I'd like to ask with the polypropylene sling, the approaches, most authors report leaving the retropubic space sort of intact, if you will.
Mm-hmm.
Not, and then you have sort of the UCLA approach where in fact they open the retropubic space like you would in a traditional needle suspension. And I'd like to ask you, does that matter? You know, and if so, what's the role, right?
I think if you look at outcomes, it doesn't matter. I think what it allows you to do is if you have your finger in the retropubic space, it allows you to do things under direct finger guidance, so you will reduce your risk probably of doing something bad. Reduce it a little. The risk isn't that high to begin with. It does cause more bleeding, and I think, in general, that's not to say you don't get big retropubic bleeds sometimes from TVTs, but I think it does cause more bleeding. It's a little bit more of an operation. Now, my partner trained that way, and when she first came back, she did them all that way, and then she started doing TVTs, and she stopped doing it that way because it really, I think, is easier on the patient to not do that.
Do you think it influences the outcome of the procedure?
I don't.
Or not?
I don't, and I think if you really look at if you look at Dr. Roz's data, it's pretty comparable to the TVT data. Shorter time. So I don't think it matters. Now, I think a time when it would, if you were really set on using a synthetic and the patient did have multiple prior surgeries, but you really wanted to do a traditional sling, then I think to do it in an open fashion is a whole lot safer. And I have done that. I've done a couple where I put a piece of polypropylene in sort of the standard way of doing it for various reasons because I was just afraid to pass the needle. Now you do have the obturator tapes available if you want to try them in those cases.
Thank you. Very interesting talk. I was interested that you commented on the use of tape, tension-free tape, that sometimes applying a little more tension in the presence of low urethral pressure and infectious problems. Would it be a fair comment that your use of urodynamics would be to identify a grossly overactive bladder or a low urethral pressure, otherwise it would play little role in making a choice for these areas?
Well, I think when you think about why is urodynamics helpful? I think there's a couple of reasons. Number one is in cases where there's mixed incontinence, I think it's of some prognostic value. I also use the voiding phase because if patients don't void normally, I will, if they void by abdominal straining or if they have poor detrusor contractility, I think that there is some risk that they're going to have problems voiding afterwards. That's where it's really the most useful for me, not so much in the leak point pressure anymore. Now, I don't put extra tension on the mid-urethral sling. That is theoretically something that one can do. When I want to put more tension, I've always gone to a more traditional material, autologous or biological. So I don't tension, I try and do them the same way every time and put no tension on them. If I decide I'm doing a midurethral synthetic sling, whether it's traditional or obturator or whatever, it's not going to have any tension on it. So I don't use it to tension, but the fixed urethra, you can just as easily make that diagnosis on physical exam as opposed to urodynamics. So for me, the urodynamics has become less of an issue of looking at the characteristics of distress incontinence and more of looking at the bladder itself and how the patient voids. And I think it does give some prognostic value. And I try to be very honest with my patients. And if I can tell them, look, you're at higher risk for this happening, and it happens, they really are less upset with me than if I didn't discuss it or just sort of passed it off.
So do you routinely do lateral cystograms or just Q-tip tests or just examine them?
If I do, if we're doing video urodynamics, we have that. If we're not doing video urodynamics, I would do either an eyeball physical exam or a Q-tip test. I don't do Q-tips on every patient that comes in, but I think maybe I'm wrong, but I think you can get a pretty good idea of how mobile urethra is just from examining the patient.
And for neurogenic incontinence, incompetent bladder neck, you're doing an open procedure, augmentation. What's your substance of choice for a sling?
Autologous rectus fascia. I can't think of a good reason not to use it because unless the patient has some abdominal wall defect.
There's no role for the synthetic?
I mean, you can use them, but I think rectus fascia is worry-free, almost worry-free. You're right there, you're open anyway, and I've used it through this incision, I've used it through this incision equally well. So I love rectus fascia. I think that God, if some company could have figured out how to charge for it, it would have been the most popular thing in the world.
We have 30 seconds left. I have to answer the question on prostate cancer.
Sure. I won't be able to answer it, but sure.
And a comment.
I can't handle a whole grand round without something about cancer. How about PSA there? What is your experience with the sling and the
pretty good. I've done about 40 male slings now, and originally when we started doing them, we did not have any selection criteria other than that's what the patient chose. And what we found is that patients who have high-grade incontinence, as determined by pad testing, those are the ones that don't do particularly well with male slings. Now, high-grade is probably somewhere above 400 grams a day, so these are very incontinent patients. If you look at our patients who are less than 400 grams a day, our success, as defined by either no pads or a pad test of less than 12 grams, somewhat arbitrary of a number, or a greater than 90% reduction in volume. So it's a pretty strict success criteria. It's about in the upper 80% for the patients with lower grade incontinence and about 25% in the patients with higher grade incontinence. So at this point, when patients have high-grade incontinence, I don't recommend it. Having said that, I just had a patient with 600 grams, a physician who absolutely, he's been incontinent for years. He didn't want an AUS. I did do it, but he knows that there's a 25% chance it's going to work. So it's a fairly simple procedure to do. There's a little bit of a learning curve, not from results, just from making it easier for you to do. But not too bad. I think it does have a role, but it's not quite as good as an AUS, especially for the high grade.